At this point, I'd like to turn it over to Dr. Joseph. Dr. Joseph, it's your show from here on out. I believe you do have a presentation to share this morning, and we're always looking forward to finding out the latest news related to COVID.
Great. Okay, well, what I was saying is it's going to be a brief update. There has been so much going on. You know, when I am so honored to get an opportunity to share some information. The hardest part from my perspective is deciding what not to say, because some of the things you'll see that I'm going to talk about today are things that have happened this week that are just dramatic in the way we approach COVID. So I picked a few things that I've decided to show slides because some of these things are very difficult to understand without some cartoons or with some graphics. And so this next slide, and Steve, you'll tell me, is this next slide showing a little cartoon of a virus in the middle?
Yes.
Okay, great. So this cartoon shows our goal in protecting ourselves and treating COVID. In the middle, the red ball with the spikes sticking out of it is a virus. And those green things that look like a Y or an upside down funnel or an Erlenmeyer flask, those are the antibodies that we make. All vaccines are designed to make those green antibodies, and the purpose is for those antibodies to attack the spike on the outside of the virus, nothing on the inside. We just forget about the inside of the ball because it's the spike that is the business end of the virus. It's the spike that attaches and invades and causes infection. If we can block the spike, then we're protected. All vaccines are geared toward making those antibodies that block the spike, and many therapies are giving those antibodies in an attempt to block the spike. And this is the way it has been since the beginning until we started to see changes. And what we're seeing now is a new variant. Now, variants are named according to a nomenclature that's very, very difficult to discuss. So because of that, the World Health Organization elected to name them with Greek letters. So there is the wild type or the ancestral strain. That was the very, very first infection that was identified in November of 2019. And then whenever there was a change in the activity of the virus, the World Health Organization assigned a name. So if you recall the Greek alphabet, it was alpha, beta, gamma, delta, and we are now on Omicron. I learned the Greek alphabet in college. I still pronounce it Omicron. I was surprised to find out that it is acceptable to call it Omicron, but I will refer to it as Omicron. This is the 15th letter of the Greek alphabet. So the 15th variant that has been followed very carefully. Now, what we're looking at to the right is a picture of the Omicron variant. And those orange things that look like cauliflower, that's the spike. And that's what's new. The spike has changed. So all of our previous protective antibodies, all of our previous vaccines, all of our previous antibody therapies were geared to the spike of the original virus. Now we have some 30 mutations in this spike. And this spike is more resistant to the vaccines, to the medicines, to the antibiotic therapy that we've been giving, or I should say the antiviral therapy. So that's what we're dealing with, is a concern that all of these mutations in the Omicron variant are going to create a new problem for us. Now, I'm going to emphasize this, and I'll emphasize it again a little bit later. We are just watching this. If you consider the COVID pandemic a learning process, consider that we started out in kindergarten and maybe now we're in high school or junior high. We are learning and changing the way we approach things as we learn new information. So we're now dealing with the news every day about the Omicron variant. And I'm going to show you next an extremely complicated slide just to make one simple point. If you look at the red line, if you can see my pointer, this is the red line of Omicron. All other variants, all 14 other identified variants are mutations from each other. They all came from the same part of the coronavirus. What is concerning people the most is this is the first variant that is completely different from every other variant identified. Now, that doesn't mean that it's better, worse. It just means that it is raising eyebrows. And the reason you're hearing about it so much is because we don't know what this is going to do. You know, it's like living in a cabin, opening your door and seeing a wild animal, and you're not real sure if that wild animal is going to be something very serious, something very life-threatening, very dangerous, or if it's going to be mild and go away. So we just don't know. And that's the part to emphasize. There have been many questions about where the heck did this come from? And these are three of the most common theories. That is, it came from a population where we do very little surveillance for COVID, very little serious sequential testing. And that may be the situation in some developing countries in Africa. Or it could have been a chronically infected patient, and that would be an individual who has an immunocompromised state and just can't clear the virus, can't get over it. And this brings up a very important point. Variants only occur in infected people. They don't occur naturally. For a mutation to occur, it requires viral replication. And viral replication only occurs in people, at least so far. This is most likely. Now, there is the possibility that the replication occurred in a non-human species, such as a bird or a bat or a turkey, but there's really little evidence. All we can say is it's a theory. But the important thing is that if we can avoid infections, then we avoid variants. It's that simple. They only occur in infected people. Now, this next slide, I think, is something that is going to be a little bit surprising. You cannot turn on the news or on any of the media that we use, whether it's social media or television or radio, without hearing about Omicron. But we have only 40 cases of Omicron in the entire United States. Yet we have 1.5 million new positives. That shows us on this slide that the frequency is very, very low. Now, I'm going to tell you that this is unfair because all of these 1.5 million were not checked to see if they had Omicron. But of those that were sequenced, where we're looking for Omicron, of 80,000 that were sequenced, and this is selective testing. Sequencing, by the way, is a very sophisticated laboratory test where you can identify variants, where you're really looking at the genes. And 80,000 have been tested so far in the United States. And this is during the 16-day period of November 22nd to December 8th. So very recent. The 16-day period, 80,000 new positives were checked for Omicron, and we only have 40. So that still means that 99.9% of the new cases in the United States are likely Delta. So I think the thing to emphasize here is Omicron is present, but we don't know very much about it. And it takes me to this great quote that is not mine. I plagiarized it, but I think it's fantastic. We know more about what we don't know than about what we know. In other words, Omicron is considered a variant of concern. In other words, we're concerned about it, but we just don't have any idea how it's going to play out. And I can tell you that I still am involved with the CDC. And the reason there's so much emphasis on Omicron is because we were a little bit late getting out of the chute. There has been a lot of public criticism of the CDC, the NIH, of the World Health Organization. of not acting fast enough. And I can tell you right now, all of the effort going into Omicron is to make sure that we don't get in that situation. Every drug company is working on Omicron. Every vaccine company is working on Omicron. And I'm pretty confident that we're going to do everything that is reasonable not to get too far behind. So that's the Omicron story as we are right now. 40 cases in the United States with tremendous vigilance. Now I'm going to shift and talk a little bit about what's going on with vaccines, why there is so much discussion about vaccines, both in the laboratory, politically, and certainly in the news. This slide may be hard to read, but let me tell you what it says. Very simply, vaccines deteriorate, the effectiveness of vaccines deteriorate over time. That's all this slide is intended to show. The pink or the salmon color is the Pfizer vaccine. The light blue is the Moderna vaccine. So Moderna may last a little bit longer, but importantly, both are deteriorating over time. And what we think we know is that the higher the antibody level, the higher the blood test level after a vaccine, the more protected we are. We don't even know how much it takes to protect against Omicron, but we do know that it takes more than Delta. So in the test tube, you can compare Omicron to Delta and see how much antibody it takes to fight each of those. And Omicron is clearly more resistant. So we don't have an Omicron vaccine. So instead of having an Omicron vaccine, we're giving another dose of the original vaccine. And it seems to work. And I emphasize the word seems. We have to be honest about what we don't know. But it seems to work. Certainly it works in the test tube. So the recommendation now is that everybody who has been 6 months out from their last vaccine get another one. I'm going to put this on a table and go through a few things next. So these are the recommendations, a very busy table, but we're going to focus on the booster down here because most persons in the United States are in the booster range. So for the Pfizer vaccine, if the second dose of the Pfizer vaccine was more than 6 months ago, a booster is recommended. And as of yesterday, it's now down at the age of 16. Pfizer pushes the FDA harder than anybody else to look at their data. And yesterday, they relooked. There's nothing new, but they relooked at the studies that were presented to the FDA and said, yep, we can take the recommendation from 18 down to 16. And this was all based on the cardiac side effects of vaccine. They looked at it for those who were 16 and 17 and decided that there was no difference in that group. So Pfizer now, if an individual is 16 or 17 years old, can get a booster. Moderna is still at 18 years of age. And again, it's 6 months after the second dose. And the Janssen vaccine, J&J, which is a single dose vaccine, clearly a different structure, has always been and still is, get a second dose if it's been 2 months. Now, in the United States, the recommendation has been made, and it is an important recommendation that you can get any booster manufacturer that you want. I should say that's available. It's not that you want. So I have had many, many patients who originally got the J&J, but they go in for a booster and the pharmacist says, we're going to give you Moderna or we're going to give you Pfizer. And the same is back and forth. In other words, mix and match is okay because we don't want anybody not to get a booster just because of availability. So anything works. And there's been enough now to suggest that that's very, very safe. So I would prefer, remember, this is December 2021. This isn't the end of the line. So if a mix and match doesn't work, we have time. A mix and match may actually be better than sticking with one product. So I'm making no recommendations except get a booster when the time is due, 6 months after Pfizer or Moderna and 2 months after J&J. So that's where we are. Remember that if the vaccines prevent infection, and there's nothing better than the vaccines to prevent infection, then we prevent variants. So still, in the United States, we are in the era of an epidemic, not a pandemic. So an epidemic would be the United States, a pandemic would be worldwide. Clearly in the United States, we are in an epidemic of infection of the unvaccinated. They still represent 96% of new infections. And it's in those people where there is a risk of a variant developing. Now, this is some new stuff. This has not yet hit the lay press heavily, but there are two pills, two different drugs that one can take after infection. So the Merck Ridgeback product has already been approved by the FDA. It's molnupiravir, and the efficacy is based on, does this prevent hospitalization? So if this is given to 100 people, it reduces hospitalization by 30%. So far, a very, very safe drug. No studies of new drugs are ever done in kids. No studies of new drugs are ever done in pregnant persons. No studies of new drugs like this are ever done in the immunocompromised. So it's a limited group of people, but it looks very good. This already has authorization from the FDA. To the best of my knowledge, it is not yet available. The United States government has guaranteed Merck that they will purchase millions of doses. And so now we're waiting to see what the distribution program is going to be. It is said that it's going to be available and free to anyone who has COVID. Now, there's a good and bad about this. Obviously, it's good to have a therapy. I hope this does not represent a deterrent to individuals who are vaccine hesitant. In other words, I just hope that individuals don't say, look, I'm not going to get the vaccine because there's pills going to be available to treat it if I get sick. These pills are not as good as the vaccine. The next one is the Pfizer drug, same thing. It's a 5-day course of therapy of pills. It comes under the brand name of Paxlovid, and it appears by the original work to be even better than the Merck product. Now, this one is not yet authorized by the FDA, but the word at the FDA is they are going to be looking at it during the month of December. And if the information presented to the FDA is as good as Pfizer claims, it will likely be authorized before the end of calendar year 2021. Then it's out of the hands, as far as I'm concerned, at least as far as my knowledge, it's out of our hands regarding production, distribution, and availability to those who may need it. And then this is my last slide. This is a tremendous breakthrough. Now, this is probably something that most have never heard of, but this is a drug for pre-exposure prevention. Now, pre-exposure means that you can give this to a person before they even get exposed, and it will prevent infection. The drug is called Evusheld, and you get 2 doses, 2 shots, one in each side of the butt, and it looks great for at least 6 months and may go on for 12 months to prevent infection. This was authorized yesterday or the day before by the FDA. The information looks good. So far, this is only approved for persons with an impaired immune system or where their doctor thinks that they may not have a good response to the vaccine. So it's a very limited use, And again, if the use gets expanded, if the availability gets expanded, I hope this is not a deterrent for those who are eligible for vaccine and have not yet taken it. But this just gives you an idea of how exciting things are going on to address COVID. Now, currently, I should say this drug was developed before Omicron. It has been in the development for a year. So the effectiveness against Omicron remains unknown. But I have been assured by the manufacturers of this company that that's all they are doing. They're looking to see if this particular drug prevents Omicron. But very, very exciting change. We don't have pre-exposure prophylactic medicines for many diseases, and we certainly don't have any that last a year other than vaccine. So this is exciting. I am going to back up one slide. I forgot to mention something about the orals. These appear to be very effective against Omicron. In other words, they act on a different part of the virus than the spike. The vaccines act on the spike, but these actually work on the inside part of the virus genes. And so they are likely effective against Omicron and definitely effective in the laboratory.